Welcome to Doc Secret, the show where we uncover the playbooks, strategies, and stories behind the most successful dental and medical practice owners and the companies that serve them. This show is all about building the best practice. Whether you're a dental or medical student dreaming of private practice, a seasoned doctor looking to grow or sell, or an investor exploring the healthcare space, this podcast is for you. I'm your host, Kevin Carl, and in today's episode, we're diving into the world of modern fatherhood and masculinity. Let's get started. Welcome to Doc Secret. Our guest today is Dr. Dan Singley. Dr. Singley is a licensed psychologist, researcher, and widely recognized thought leader in the field of men's mental health and perinatal psychology. He's the founder and director of the Center for Men's Excellence in San Diego, where he specializes in men's issues, new fatherhood, and the transition to parenthood. Dr. Singley is a past president of the American Psychological Association's Division on Men and Masculinities, and his award-winning research has been published in leading journals, shaping how clinicians and policymakers approach men's behavioral health. A dynamic speaker and sought-after consultant, he has been featured in outlets such as the New York Times, the Washington Post, and NPR. His mission is to break down barriers to mental health for men, equipping them with the tools to thrive as partners, fathers, and individuals. Today, he'll share his insights on how behavioral health professionals and the men they serve can reframe masculinity in ways that improve well-being and strengthen families. Dr. Dan Singley, Dan, if I may, welcome to the program.
Yeah, no, Dan's great. Thanks for having me on.
Well, Dan, I'd like to start by setting some context for our audience. If you would, tell us about your path from UVA and UC San Diego to founding the Center for Men's Excellence. What personal experiences shaped your focus on men's psychology?
Sure. I had in some ways kind of a weird career for a licensed psychologist. When I was in grad school, I was not focused on men's issues or masculinities. I was focused on whiteness and white racial identity development. I'm a white guy. The old joke is research is me search. And so I didn't index much on the gender thing. That came when um, my wife and she gave birth to our son about 10 days before we moved from the University of Maryland, where I had gone to grad school and she had finished her MBA. And we moved out to UC San Diego to do my predoctoral internship and then a postdoc fellowship. And it was within the first week that I had started at UCSD at the counseling center that local psychologist who's now a very good friend and mentor of mine, his name's Dr. Jeff Jones. Jeff came in and talked to our intern cohort about expected dads, new dads, the psychology of men, the APA division on it. And it just blew my mind because I had a newborn and he's talking about the psychology of early fathers. And it actually I felt a little embarrassed, frankly, like, why haven't I been focused on why don't I take my shrink fu and focus it on fathers, or being a man or whatever. I just did like most guys, you don't stop and really think in concrete ways about my gender, or same thing with white people. We tend not to stop and really sort of deeply index on, well, what is my whiteness and so forth. That's part of what drew me in to begin with. And and that brought to me the realization that I had gone through an entire PhD program, including an entire course, like a doctoral level course on gender, without ever talking about masculinity or cis men. Like in that course, and this is a pattern that gets repeated over and over and over again, we talked about every facet of gender, femininity, queer, trans, gender nonconforming, the whole thing, but never directly addressed men's issues or
Interesting.
masculinities. And so when Jeff came and talked, I was like, whoa. So I was like, I'm going to finish post-talking and then I'm going to call you. And I did. And he took me under his wing. I got a First Five grant. We set up the Expected Dads class. I started getting involved in the San Diego Psych Association as a men's issues committee. decided to chair that, got involved with the APA, and I really sort of backed into now my umbrella area of expertise and focus is men's issues and, the psychology of men and masculinities. Within that, my research is on early fatherhood, father's involvement with infants. What are the psychosocial factors that either are serve as barriers to or facilitators to fathers being involved and engaged with their babies, but also themselves making a healthy transition. And while all that was going on, I worked at one startup for 4 years. It was virtual back before it was cool. Um, it got bought by VCs and started to suck for all the reasons you would think it does. Then I went to work for a different telemental health one. I did that for about a year and a half. And it was at that point, this is important, for because this being a show for folks that are in the profession and want to. I got the best professional development coaching advice from my wife, who again, she got her MBA. We co-manage our practice. And she saw it. Like, my dad was a company man. He worked for an energy company. You worked there for 30 years, the pension, the gold watch, the whole thing. And so that was my frame. That's what I imprinted on. So I kept thinking, I have to work for an organization. I have to work for an, and my wife sat me down, and I was scattered at the time. I was doing like whiteness. I was doing online methodologies. I was in positive psychology, fatherhood, men's issues, like, whatever. I have ADD and nearly unlimited energy, but I was like spread too thin. And my wife sat me down and kind of gave me the rolled up newspaper to the nose. And what she said that was extremely important was, um, you have to give your research, your practice, your consultation 18 months to take off. And in that time, I forbid you to work for anyone else. She literally said that. She was like, we're going to be fine. We're not going to be out on the street. Like, you have to take the time to do that. The condition was anything I was doing that was not about men or fathers, had to let that go. Get off that board, stop that project, get off that committee. And she's the one that basically said, fathers and men's issues are your North Star. Let everything else go, focus that. I did it, and I've never looked back. It's been incredibly fulfilling.
Wow. Well, I know you mentioned earlier in your comments some of these leadership positions you held. I hear what your wife sat you down and told you directly, right?
Yeah.
But you've since then, I'd love to understand sort of the order of things. You've led as president of multiple APA divisions and you won practitioner of the year. Obviously, something is working well for you and you've made investments of your time, energy, and resources into these roles. How did these leadership roles influence your clinical practice and the vision that you and your wife have for it?
So this is a great question. It's funny. I am profoundly uncomfortable with praise. I, I I'm just putting that out there as a bit of a disclosure. It is true. I've had to like get over the deal where somebody says like, "Oh, you did this thing well," and I'm like, "Oh, you don't know what you're talking about," because it's just crappy to do to that. But anyhow, like, thank you. Along those lines, actually, at the most recent APA convention, like 2 weeks ago, I was also awarded the Distinguished Contributions to Psychology award, which was lovely to be recognized by my peers,
Congratulations.
largely for like research and policy stuff. Um, but for me, I have never wanted to just sit in the consultation room by myself and just see patient after patient after patient. Like I did a good amount of that early career because,
Sure.
baby needs shoes and kid needs braces and that's what you do. But along the way, I have always had an eye toward teamwork and not being stuck in a silo and trying to find who are the people, who are the organizations that are like-minded because you get more reach that way in terms of the message and so on. So, I started locally, and so my first, um, board position was that I joined the San Diego Psychological Association. I got on their board. It was a 3-year gig and ended up getting much more connected with some pretty senior people,
Mhm.
and just some lovely individuals that are very good friends with at this point. Um, and that absolutely fed back into the development of my practice and getting known. Men's issues is not a common specialty within psychology.
Mhm.
Right. In fact, so anybody that's listening, if you have a therapist, if you're seeing that therapist, if you really want to mess them up at some point, when you go in, ask them this question: "Hey, I'm a male. what kind of formal training have you had about working with males in psychology? And they're probably going to be like, well, I have lots of experience, or I am a male, or this and that. But that's not the question. The question is, have you actually looked into the evidence base, the research, the best practices, and so forth? Because they're there. But most of us do the same thing that males do about our own gender when you think about males. So for that
Mhm.
reason, being a male who's into men's issues and healthy masculinity and so forth is a little weird. And so people are like, huh. Usually the first question is, are you like pro patriarchy, men's rights, and male supremacy? All that. I'm like, no, actually, we're working against that. We're trying to lift all people up. But being in leadership positions like that has absolutely helped to foster more awareness of this kind of work, that it's out there, but also opportunities to get out there and do trainings and presentations and consultation when, say, a neonatal intensive care unit excuse me, wants to involve fathers. They know who to call. And
Mhm.
after that, I was more sort of, then I moved into APA, and started doing work at that level, and leadership and governance has just remained an important part of what I've done, actually. So I'm now the immediate past president, right? But for the division, on the Psych of Men in APA. I was actually just elected to be our representative to the APA Central, the Council of Representatives. Every division sends people to it to sort of
Mhm.
advocate and be part of the decision making, for the APA Central apparatus, and I'm going to be doing that as well. And it has kept me connected with really lovely people. It has opened up opportunities for me to be able to get in front of people and talk to them about some of these fatherhood and men's issues, topics that I'm super passionate about. But again, I'm not just a researcher and a consult. Like, I'm a small businessman,
Mhm.
right? My wife and I run a practice, like, are substantively like that, this, and we have other clinicians that work here and so on. And so always present is attracting the clinicians that have the aptitude for and are interested in doing this work, and maintaining a solid referral base. And so
Sure,
getting
yeah.
out there and being able to present on a lot of research, including my own, absolutely helps in terms of folks being like, oh, like, you seem like you're a mover and shaker in this. Like, if men's issues isn't popular, fatherhood and early fatherhood, nobody's sure. People, they hear it, they're like, oh, that's great. Like, yeah, dads are great. But I'm like, yeah, but the actual science, the social science of it, and then programmatic applications is not so common. But doing all that governance and committee and leadership work has helped. As at this point in my career, I'm really bringing down the amount of face-to-face clinical work that I'm doing,
Mhm.
and I'm doing more and more policy advocacy. Like, I'm not in the legislation meetings at this point, but I'm rubbing elbows with those that do, and that sort of bigger picture stuff is a direct extension of the governance and leadership stuff I've been doing throughout my career.
Well, great lessons for our audience for how to make that work, not only as an active part of your practice, but in terms of giving back, because I know it does take a lot of folks to make those broader policy decisions move, and it takes involvement from the industry. So hats off to you for your involvement there. I'd love to dig in on something you just talked about, which is some of your publications and, quite frankly, some of the programs that you've started, and you've started a number of them. So I'd like to talk a little bit about some of those. You founded Basic Training for New Dads. I'd love to just understand what inspired that initiative, and why did you step into reproductive psychology and fatherhood-focused care specifically?
So back to the research is me search thing. When Jeff Jones mentioned classes for new dads and expectant dads, I had just gone through the pregnancy period with my wife, and we did the classes and the bringing baby home and all that. No one addressed fathers, really. Like, fathers are support, and we're certainly within reproductive and perinatal mental health. It is tricky because the trope for dads is protect, provide, right?
Yes.
And from birth educators, usually what you hear is, to the extent that they address like the father or the non-gestational partner, it's you need to be supportive, which is perfect, right? Be supportive. But very rarely does a birth educator stop square off, look at a dad and say, and dude, you're gonna need support too. And you're gonna need support outside of how awesome your partner is. So like nobody, I certainly was not told that. And when I went back to talk to Jeff and I was like, hey, I want to work with you. This is something I want to do. He said, well, we don't really have a class for the expectant dads. So let's do that. And so he, as I say, he took me under his wing, helped me to get a first five grant, built out the basic training for new dads classes. And we've been running those since 2007.
Wow.
And we're the only game in town. I mean,
Yeah.
literally, we are the I mean, in town, maybe even the state.
Hmm.
And at the same time, we have trouble getting enough people into that class
Yeah.
because
Is that an
people don't
awareness
think about
thing,
it. It
or
is.
is it
It is.
stigma, or is it both? Or I'm just curious.
Mm, so the stigma is less and less because the
Yeah.
class isn't mental health. The class is just
Hmm.
fathers. I happen to be a shrink who's teaching a class on but I say upfront, like, there's not psychotherapy, you're in the room with a shrink, but, don't hold that against me, because it's really just going through and talking about different aspects of fatherhood, of the transition, of some ways to kind of, like, do it as healthily as possible. But, yeah, I think largely it's people a brilliant colleague of mine said years ago, "If you don't know something exists, you won't look for it."
Great quote.
And I
Yeah.
believe that's largely what's going on with respect to the fatherhood classes, because I hear so many people like, I was just at a conference, and I'm in the expo hall, and I'm working apart from APA, Postpartum Support International is
Hmm.
also a nonprofit that's been, a professional home for me with lovely humans, and I'm happy to talk more about that, but I was at APA, being an expo, booth person for Postpartum Support International, and people would come by and say, man, I wish I'd known about y'all. I wish I had known there were things. I struggled, my husband struggled, blah, blah. And so I'm at the same time, I'm like, yeah, well, now I'm that much more passionate about let's broaden the tent. Let's get the word out there so that people can get it in a preventative and a proactive way.
Well, that's great. Let's talk about that bigger umbrella, if you will. It's I think certainly related, which is International Father's Mental Health Day. What's the story behind founding that? And I know you had a role there. I'd love to hear more about that, and I'd love to understand how that deepened your mission to support men as you were going through that founding process.
Yeah, yeah. So International Father's Mental Health Day started with a couple of my buddies and colleagues. Um, Mark's in the UK, and another Andy Mayer, psychologist in Australia. The three of us kind of got together and said, "Hey, let's draw some attention to this." And decided that we're gonna take the Monday after Sunday Father's Day, like in most Western countries, to be International Father's Mental Health Day. And the idea was to raise awareness about the fact that plenty of dads struggle
Mhm.
and have difficulty. Like, 1 in 10 dads gets postpartum depression, not just a little down, but actual major depressive disorder with peripartum onset. Nearly 20% will develop some kind of anxiety disorder, not just I'm a little sleep deprived and a little stressed, PTSD, OCD, generalized anxiety, specific phobia, and so forth. But people just don't know that. And so International Father's Mental Health Day was our effort at getting the word out. And so my buddy Mark, he's Welsh. He actually experienced postpartum depression and anxiety, and
Mhm.
he has ADHD, and he's very, very much an advocate for looking at fathers and early fatherhood, certainly in the UK, but then as an ambassador more broadly. And then as we've gone on, we've kind of pulled other people into our merry little band, and really over the past couple of years have put more time and effort into it. We're now working with an awesome Australian nonprofit called the Gidget Foundation, and Gidget has really sort of taken it and 2.0'd it, and I'm thrilled with that. We just want people talking about it. Even if it's once a year and it's like, what, 10% get wait, dudes get postpartum depression and 10%? Whoa, okay, like that's all we want.
So, Dan, I'd like to get into the science behind this deeply. You've been in the depths of the science, and so I'd like to dig into that here. You co-authored the book "Parental Mental Health: Factoring in Fathers." Could you share with us broadly, help educate us here? Why is a gender inclusive approach critical during this transition to parenthood?
So my co-author, Jane Honigman, she's up in Santa Barbara. Jane is actually the one who founded Postpartum Support International back in the day, and she is a force to be reckoned with. She came to me and said, "We got to write this book so that men's voices can be heard." And she said, "I'm not a man, you are. Let's do this." I said, "Okay." Um, the the title, Parental Mental Health, reflects the direction that I believe the entire field of what is usually referred to as maternal mental health needs to develop. Because within reproductive or perinatal mental health, there absolutely are pockets that are exclusively maternal or exclusively paternal or exclusively trans, right? Um,
Mhm.
but go back to what I said before. If you don't know something exists, you won't look for it. If the field is called maternal mental health, you won't look to the dads. You will not look at and for and try to anticipate what works and what doesn't, what helps these dads. We're too busy telling them protect, provide.
Mhm.
And top level, that's very much one of my sort of ongoing crusades in the field because it's just inaccurate to call it maternal as an umbrella term that truly includes parents of all genders,
Mhm.
not just male identified ones.
Mhm.
So for example, like LGBT, like gay and lesbian and trans parents are a smaller but rapidly growing population in this space, and they're very vocal about it. And that is, I think, every bit as important as we start looking at, well, what does the science of gender informed intervention look like? In my case, I'm focused on the dads, but we need to do it more broadly for around gender, around family constellations. Like I'm in Southern California. Here we have like polyamorous polycules and thruples and all kinds of different, family constellations. And it's not up to me to say what people should or shouldn't be doing. It's more like, okay, my job's to help out.
Mhm. Well, let's talk a little bit about this missing link because I think that's some of what I'm hearing is that there's a gap between perception, public perception of masculinity, and what maybe a more ideal state would be. Could you describe for our audience what that missing link is as it relates to the general public perceptions of masculinity?
So yeah, I'm gonna go on a little rant here. Hear me out, edit me as needed. The
Oh,
thing I want to
good.
say is this. I keep politics the hell out of this stuff. That's not my frame. My frame is what's functional
Mhm.
and what does the science say and how do we get the message across, right? So it is no secret that at this point in our society, identity politics and culture wars and so forth are very much woven throughout the tapestry of these discussions and issues. For me, um, really, what I'm hoping to have happen is that we can take the awareness of traditionally what we have looked at as being a man, right? There's all this stuff out there about toxic masculinity and the manosphere and masculinity is inherently problematic and so forth. What I say is this: masculinity is not problematic on its own. That the science does not back that up. What most of the social science in this area shows is problematic is being rigid about only being that traditional, aggressive, stoic, independent, nothing knocks me off my spot. I'm like super successful and so forth, without also being able to balance that out with empathy, compassion, being a good listener, accepting influence from other people when that is what's most functional. Like,
Mhm.
like the hardest core, most like like Marlboro man dude is gonna have problems if he goes back to a partner and tries to like, you better ask how high on the way up when we're disagreeing because I'm here to tell you that stuff does not hold water. But just I was talking to a guy this morning that had that exact same thing going on. And so what what my colleagues and I have pointed to is that men die 5 to 6 years younger than women do. We account for 80% of the suicides in this country. We have a disproportionate number of divorces and deaths of despair, depression, and and the pandemic of loneliness and isolation in this country, in particular for men.
Mhm.
All of these factors together clearly point out ways that men and boys struggle and suffer, but most people simply aren't focused on them. And again, most of what the social science research has shown is that it isn't masculinity that causes those or contributes to those. Rather, it's the rigidity around only being that one like hardcore, badass guy without being balanced.
Uh-huh.
So what we advocate is that the healthiest men are ones that are able to have balance and flexibility.
Mhm.
I can be tough and hardcore in a contract negotiation over here, and then I can be sensitive and empathetic with my kiddo or my partner or my close friend over here. You live longer, you have more fulfilling relationships, you get divorced less, you're less likely to kill yourself. Like all of these things that we want for the boys and men in our lives.
Mhm. I'm curious, is there a international dimension to this? So, for example, there's this traditional Americanism of, carving a way out of the wilderness, so to speak, highly individualistic.
Mhm.
And then there's maybe a European, even an Asian, Southwest Asian. There are different international views on men, masculinity, fatherhood, male roles. Does the science bear out that this is an American issue or is it a global men's issue?
It's global, and you have to factor in different cultural aspects. In fact, I'm thinking, a colleague of mine that I'm in contact, he's a big wig at the Movember Foundation in Australia, and we were having a little bit of a back and forth, and he was pointing out, like, Australian dudes tend to be pretty, like, traditional guy too,
Mhm.
and then you and then and that's functional and beneficial in some situations, but not in others. I can also speak to the prevalence data on paternal postpartum depression.
Mhm.
And it's absolutely a global phenomenon. We see it on every continent where we have actually I don't think we have Antarctica. Like maybe there are, depressed penguins down there. I don't know. But in all the ones that we've actually assessed, yes, that facet of men's health and then it would roll up. But the reality is most people are not doing prevalence research. The People's Republic of China, I'm not familiar with, men's depression research there. I don't know that it's on people's radars. And
Mhm.
there are absolutely cultural implications for then what traditional masculinity looks like. There are some pretty enduring themes, though. So, for example, in the mid 70s, some researchers, David and Brannon, did this cool like cross-cultural study where they looked at what are the cardinal tenets of masculinity across a bunch of different cultures, and it was exactly what you think it is. It's anti-femininity, which doesn't mean you hate women. It just means that whatever it is to be feminine in your culture, the number one way to be traditionally masculine is don't be that,
Mhm.
right? And then from there, it's you got to be successful, you got to be independent and stoic, and you're aggressive, and you jump out of planes, and you're a sexual dynamo, and all this stuff. And those are fairly universal. And then it's a question of to what extent do people, on the normal curve, adhere to those aspects of it. But yeah, it's
Uh-huh.
not just an American thing by any stretch.
Well, I think what you're highlighting then in some of your comments is that there's this gap, right? And I'd love to understand your perspective as it relates to the gap in current mental health services when it comes to supporting men, particularly new fathers. How big is that gap between the need and the providing of those services?
It is really big for people in general and for men in particular. Let me let me let me address this from a couple dimensions. One is, it is not the case that men help seekers in mental health need to work with men. You can do very, very helpful, successful work with people of any gender. I find it's more about the person and their experience than it is about the gender or the degrees or whatever, right?
Uh-huh.
That being said, recently there was a figure released which said that s- the 5% of the psychologists under 30 are male. 5. And this is a major, major flip flop. Like, right? Psychology was developed by a bunch of guys look like me, bunch of like, old white dudes. Um, and it has shifted very, very much to largely a pink collar profession for a variety of reasons. But mental health has been, feminized in some important ways. Some of my colleagues have done interesting research
Mhm.
along those lines. Um, but so there's the underrepresentation of males as practitioners. And the same thing, you follow the professional pipeline, most grad schools have, say, between like maybe 12, 15, 20% maximum male identified students in the pipeline.
Wow.
Does having a male therapist increase the likelihood that they may go see them? Yeah, for some people. I mean, our practice here in San Diego, as you meant, Center for Men's Excellence.
Mhm.
We're trying to push past all that stigma and say, hey, come in. We're not talking about don't be crazy. We're talking about excellence and we do gender specific therapy and so forth. So that's one thing. Aside from that, there is what I would say just the well established research around men's help seeking, which is we don't want to do it.
Mhm.
So you could have all the access in the world, but if all we hear is be tough, protect, provide, what part of that suggests that I get to feel broken and go have somebody else support me, right? So there's a lot out there. Like gender policing happens by all people to some extent or another, not just men to men, not just women to women.
Mhm.
There's nuance and all that. But like that part of things is extremely important. And then there's what I was talking about earlier. Hardly anyone in mental health has specific training in the evidence-based practices related to men and boys. And
Mhm.
because I talk to people about this a lot, I'll usually get essentially kind of like dismissive, mealy-mouthed answers like, well, I've seen so many guys, I get it. And I'm like, okay, what if I said that about trans men? Because there are APA guidelines around working with transgendered individuals. Yeah, I got it. I have a trans friend. I don't need to actually go to the science and learn that. People would lose their minds,
Mhm.
and I would be wrong. But it's difficult for folks to kind of get behind that when we're talking about men writ large. Like people sit up and salute when I say black men or or Latino dads or trans men or something. Then you get mostly folks like on the progressive left are like, yeah, okay, I can get with that. But when you talk about men and boys writ large struggle and suffer, and we need to allocate time and resources, particularly when you don't get to talk about DEI. And here I am saying, "Hey, let's do affirmative action for men and boys." Like,
Mhm.
what could go wrong there?
Yeah.
But here we are. Like, I see it as absolutely needed. It didn't just start. So those to me are some of the really really critical factors.
Well, you talked earlier about this perinatal period, right? And I had a guest on the show who talked about equity in the perinatal period. In fact, I encourage our audience to go listen to that episode. And, she had a strong view and advocacy there. I'd love to hear your perspective as it relates to the perinatal period, as it relates to men and men's health.
So, um, the really, to me, it begins with how we socialize boys to relationships, to emotions, to family. Like, really, like, if you want to pull all the way back, it's around, fifth, sixth grade when boys start getting too cool for school and,
Mhm.
relationship means romantic, romantic means sexual. If I have mental health or anxiety, like, that's bad, that's weak, blah, blah, blah. Um, that's kind of the bigger picture societal point. As it relates, I think more concretely, um, The folks who provide education and care during the pregnancy need to think in a family systems frame, which
Mhm.
includes all the parents involved, which means they need to assess and set the expectation that they're going to be doing screenings for depression, for anxiety. Like when you look at it, the American College of Obstetrics and Gynecologists, Academy of Pediatrics, I don't know what perinatology is on about, but they have standards about doing these screenings, and hardly anyone screens the dad. There are a variety of different administrative reasons for that, right? Like if you screen the dad at the OB's office and he pops for suicidality, what are you going to do with that? You going to put that in the
Right.
mom's chart?
Yeah.
What if they get divorced? You know, like, and these things all play out. But briefly, screen. But a lot of one of the most common words that fathers that I work with who struggle during the transition to parenthood, one of the most common words they use is invisible.
Mhm.
During the pregnancy, I felt invisible. I would ask the doctor a question and they would respond to my partner. I would ask the tech a question. They wouldn't look me in the eye. They might even ignore me. The person at the front desk didn't look at it. I walked into the waiting room and it was pink and purple and there were pictures of moms and babies and the magazines were all basically all mom centric,
Mhm.
right? Or then during the birth was like, I'm not the patient. I'm on this crappy little half futon over here. Um, but they just didn't feel, yeah, well, all the dads out there are like, oh yeah, I know about that futon.
Yeah.
Um, but like, that's the thing. They felt invisible. And then in the immediate postpartum, in the absence of someone saying, bro, roll up your sleeves, get in there, change diapers, soothe, swaddle, give give bottles if that's the way you're doing it, um, he's just as likely to have received the message that he's not important. And then about a year and a half later, his partner's coming to him with emotional load, mental load, the second shift. Why aren't you more engaged? And my first question is, who ever told him he is important and central to the parenting of his baby? Who
Mhm.
explicitly told him that? Some cases they do. In other cases, it's I'm tagging you in because I didn't think really you needed to be central on this. So
Yeah, I'm
lots more I could
tagging in
say
for
about that.
reinforcement, but
Yeah.
not necessarily because I needed you on the mat when we were in the brawl, of the matter, yeah. Well, you specialize, right, in a variety of therapeutic approaches to this challenge. You specialize, for example, in all the acronyms, right? CBT, ACT, exposure therapy, positive psychology, et cetera. How do you tailor these modalities in your practice to meet the needs of men in transition to fatherhood?
So by being integrative, right? Like as a postdoc doing, a research fellowship and so on, you learn the manualized approaches. First you do this, then you do that, then you do that. But then when you're out in the real world in the wild, it's messier than that. And learning. So what I could say is, so for us here at our center, um, our modalities, be it internal family systems or EMDR or whatever it is, are all tailored so that you can bond on the work.
Mhm.
Like, another thing I should say is
Interesting.
we don't just see men. Like,
Yep.
people think, like, Center for Men's Excellence, you only see men. That is not true. We see people of all genders. I've worked with gestational trans dads and women, and also we see individuals, couples, families, like, the whole shooting match. So coming back, um, all of the acronyms and, the CBT and ACT and so forth were integrative. Our brand is evidence-based practice with a gender-informed lens.
Okay.
Sometimes that gender is femininity.
Mhm.
Right? Sometimes that gender is like oftentimes it's because we're, work overwhelmingly with men. It goes like this. You come in, you're going to get a clear diagnostic picture, a differential diagnosis. You have this is what seems to be going on. This is where you seem to be having difficulty. These are your strengths. As we understand what you have going on, then that translates into this provisional treatment plan that has points 1, 2, 3, and 4. And so between now and next session, that means go here, read this, have this conversation. And the next session, we're going to focus on specific tool, resource, blank. And you never know what those are going to be.
Mhm.
Like, I'm always a little suspicious of folks like, and I'm an EMDR therapist. I'm like, that's all you do? Like,
You need
okay,
a
okay,
variety of
cool. Like,
tools
you're
in the tool
masterful
bag
at it.
probably, right? I imagine. Mhm.
Exactly, and people resonate to different things. Like, if I'm trying an act like experiential mindfulness-based approach with someone around, like, generalized anxiety, and they're not going for it as much, like, I work with a ton of guys that are in tech,
Mhm.
and, I mean, stereotypically, right, these are, like, analytical, sort of, left-brainy types who tend to do really well with cognitive behavioral therapy because it is very difficult to dispute the basic principles of it.
Mhm.
And it's really straightforward in terms of do this, what was it like? Okay, that suggests do this or that. But the decision tree is not linear. It's very much iterative. You have to say, okay, when we did this, here's what you learned, and now maybe that suggests try one of our men's groups, or maybe go off and do this other resource, and then once you've done that, come back. So there's no one size fits all, but for us, it needs to be based in evidence-based practices with a gender-informed lens, and it's the with a male gender-informed lens that really makes us stand out.
Well, I know another thing that stands out in your practice is what I have come to learn is positive masculinity. So could you explain what is your positive masculinity approach and how does it contrast with a deficit-based model?
It supplements it. So, historically, the medical model was you come in and you're depressed, we're gonna assess you. Your depression's at a 7. We're gonna go through and do different things, teach you different tricks. Now your depression's at a 2. Cool. Go off into the world. Well, less depressed does not mean thriving.
Right.
And we take a more holistic frame. My very good friend, and now he's the immediate past president of the APA's division on the Psych of Men. His name's Dr. Brian Cole. He's a lovely human being. At the APA convention a couple of weeks back, he gave a brilliant speech about this exact point. And the short version of it is we have taken a deficit reduction model and equated that with well-being when it isn't.
Mhm.
And you can't usually one of the big criticisms, doesn't positive psychology mean it's just like, "Oh, like rainbows and unicorns and everything's great?" No. What it means is you're paying as much attention to areas of difficulty and remediating those difficulties as you are to looking at what's right with this person.
Mhm.
What's good about them? What's strong about them? How do we take good to great and great to perfect? And then how do we leverage that? And you hear a lot of clinicians say like, "Yeah, I do that. I have unconditional positive regard," or I'll talk about strengths. But that isn't pulling in the science. That isn't doing a strengths-based assessment. That isn't doing what the strengths development literature shows works, and in particular works really well with men. And I can
Uh-huh.
tell you that doing this in such a way where it's not Pollyannish and ignoring areas of difficulty, when you're able to say to a man and use male language like, "That sounds like action empathy," or "That was your courage," or "That was your heroism," or "That was your achievement," or "winning others over," um, and we can use that to look at why you're isolated or how your anxiety flares up around X, Y, and Z, it goes a long way because the guys feel seen at a broader level. So that's woven into pretty much all the work that we do.
That makes a lot of sense the way you've articulated that. Does that extend your in your therapy practice? You talked about the OBGYN office, right? And I could certainly identify that just thinking back on that. That was very female oriented at that time. Do you design your therapy spaces and outreach so that they really feel genuinely male friendly and engaging in a different way?
We do, but for full disclosure, we also market to the females
Yeah.
too. It's about half and half. About half of the folks show up to our classes and our therapies that are male, like, bro, it was time. I'm in.
Yeah.
The other half is my partner told me, "This is it. You gotta go do this." And a lot of times the partner is tired of being the guy's only source of support and connection. Like,
Uh-huh.
he won't bro date. He won't deepen existing relationships. This is an important part of the socialization. Intimacy means romance. Romance means sex. And so I'm fine to be vulnerable and do that. I can only do it with my partner. And oftentimes that causes a lot of friction and difficulty and sort of weathers the relationship over time because nobody's telling the dude, like, hey, man, having a balanced social support portfolio is not just better for you, it's better for your romantic relationship because you're not burning it out.
Yeah.
Right. But
Yeah.
that they don't hear that. So it's just another example.
Yeah. So importance of these additional relationships outside of your partner, right? Um, Well, men's mental health I know is evolving rapidly, and you've talked about some of those thematic elements in our conversation here. How do you expect father-focused care is gonna change in the next, I don't know, let's say 3 to 5 years?
Okay. So I'm putting this out there in as neutral a way as I can. Some folks see masculinity as under attack. I see it as under construction
Interesting. Mhm.
in the sense that being a man and what it means to be a man has been evolving. And certainly, like if you like sociohistorically, like go back to the widespread availability of the birth control pill and Title IX, late
Mhm.
60s, early 70s. Subsequent to that, there's no denying the benefits and the relative upward mobility compared to back then of girls and women in society. I'm not trying to paint a picture of an even playing field. That's not what I'm doing here. What I am saying is that as women have occupied more traditionally masculine spaces, that a lot of what we have feminized and thought of, this is women's work, which is domestic work, raising kids, taking care of the home, and so forth, has naturally fallen to men, partners, and dads. All right. So as what it means to be a man has continued to evolve, but it's our society according respect to males enacting traditionally feminine roles is about 50 years behind how society writ large has started to accord more respect to women that enact traditionally male roles.
Mhm.
All kinds of nuance there. I get the double standards in business and medicine and so on. So again, not trying to, but at the same time, fathers, like I think according to the most recent US census, that stay-at-home dads were one of the largest, parental groups that had largest in the sense of since the last time it had increased. It's very small. It was from like they went from like 3% to 6% or something, but that's doubling. And that in and of itself is an indicator of how those responsibilities are now defying sort of the traditional gendered, parental and couple identities, and it's all over the place. Like
Mhm.
some folks have a much more traditional setup. It's male female. The dad goes to work. The mom's the homemaker. Cool. If that works for you, great. I live in Southern California. Everyone has dual income households because nobody can afford it otherwise. And that in and of itself raises a whole bunch of questions about how we're going to do this. And well, this isn't what my parents looked like. And how do we, how do we upgrade? Like under construction, I think the male operating system is kind of getting an upgrade at this point. The trick is to keep the aspects that have been good and been working well, and not throw traditional masculinity out with the baby in the bathwater, whatever it is.
Mhm. Well, maybe speaking broadly to your fellow practitioners, how should therapists and practice owners integrate, let's call it father inclusive programming into their private practice or into healthcare groups? Do you have any recommendations there?
I do. One would be so Postpartum Support International, as I mentioned, is a nonprofit I've been working with. I'm one of our trainers. I developed a 2-day intensive training on paternal perinatal mental health. And so through PSI, I do a lot of trainings along those lines. I also just myself go out and do lots of trainings about, father involvement programming and how to do so, ways to understand paternal perinatal reproductive mental health. The APA also released guidelines to a lot of fanfare. Unfortunately, got a lot of blowback in like 2017. It's the guidelines on psychological treatment of men and boys, I think it's called. Um, and it has really good information. There were some aspects of it that kind of put people off, but if you get past the epistemology or the ideology and really all you're focusing on is what are those 10 aspects of working with men? One of those is about fathers. Another one is about strengths-based practice. I would encourage everybody who's a mental health practitioner that wants to at least get some grounding in doing this work, You can download for free from APA.org the guidelines on psychological practice with men and boys, and that is a great place to start as well. We've got stuff on our website, menexcel.com. We have knowledge nuggets, we got blog posts, we answer the question, not how, but why the Grinch stole Christmas, obviously, because of his trauma history, and his sense of his masculinity, but things like that. Like,
Mhm.
there are ways to get a sense of really what's the state of the art in psychology of masculinities and how to apply it.
Mhm. And you've got I think there are virtual groups too, right? Aren't there communities like Padre Cadre or, uh, things like that that play a role potentially in getting men involved in a way that frankly, helps solve that increasing isolation you talked about earlier? Maybe you could shed a little insight on these virtual groups or communities.
Yeah, so mostly, so we'll do the dad's classes in a virtual format as well as in an in-person. We stagger those. Um, Padre Cadre has essentially sort of worked with somebody else and started putting that energy into the platform that he's working to
Okay.
develop. It's online spaces. We do lots of men's groups. In fact, there are 6 psychologists here at our practice, but those are all in person. Our postdoc fellow, actually, Jenna King, is in the process of putting together a virtual skills building group for men. But really anything that we can do to connect these men and fathers virtually. So, for example, I mentioned Postpartum Support International.
Mhm.
We have a bunch of virtual groups for expectant dads, for new dads who themselves are struggling, and they're free. It's just that people don't necessarily know to look. So, if you go to postpartum.net and you look up chat with an expert for dads every Friday, there's also father, like virtual video support groups for them, and they're awesome.
Oh, great. Uh, Maybe broaden the tent here a little bit. What opportunities do you see for collaboration between other medical professions? So, for example, dental, veterinary, behavioral health professionals. Are there opportunities for collaboration around this concept of family inclusive care?
Oh, totally. So going both ways. So, for example, men's below the belt health, prostate, colon, testicular cancer issues, prostatitis, these sorts of things. Oftentimes, the shame around them, dudes don't want to talk about it and
Mhm.
don't tell their provider, and they might let something about that come up in talking with me or someone like me. Our responsibility to then say, bro, you got to go back to your urologist or you got to go back to your primary care person and let them know you've got one ball that's really actually aching a bit and don't stick your head. And so for us, understanding about how and when to involve the related medical professionals. On the flip side, dental anxiety and avoidance of going to the dentist, um, urologists. I have had a hell of a time connecting with urologists that see the benefit of behavioral health.
Hmm,
Even when
interesting.
they're having conversations like, you came out of that surgery and you're gonna have erectile dysfunction for the rest of your life. Okay, good luck with that.
Yeah.
Instead of, "Hey, here are some experts in men's issues," and the list goes on. I don't mean to just pick on urologists, but it's also, general practitioners, people that just have generalized anxiety. Like, you can take medication, that's better than nothing, but medication and therapy is better than just one, and certainly better than nothing. So, my experience has been that the apart from psychiatric, medical providers non-psychiatric medical providers or like psychiatric NPs, um, tend to be pretty skittish
Mhm.
about mental health, and that stigma about mental health oftentimes pervades even to those providers when we could be partnering much more easily for the benefit of the patients.
Yeah, it certainly sounds like there's opportunity for improvement there. I mean, I just think about
Yeah.
my own involvement with my own group of doctors, right? So food for thought for sure. Let's look broadly maybe at the behavioral health field. You mentioned this really astonishing number of 5% below 30 as in terms of male
Mhm.
representation in the field. What concerns do you have about that trend in the field, and what do you think the potential impact is on society and patients?
My overarching concern is that men and boys and the people who love them and care about them will struggle more than if there were people that looked like them available to do psychotherapy with them, right? That being said, there's research in this area, obviously, and sometimes het men are socialized. You can be vulnerable and open, but only with a romantic partner, or only with your mom, or only with women, right? So I'm not in any way knocking, non-male psychologists, but one of the key issues is it further reifies this idea that mental health is feminine
Mhm.
and that psychology and mental health needs to remain a pink collar profession, like with teaching, like with nursing. If there's a male teacher in the sixth grade, of course he's a PE teacher. These sorts of associations that we have, we don't say, oh, she's a female nurse. We say he's a male nurse, and it's very much the same point of saying that mental health and then mental health practice is a big part. That we just founded a task force in the APA division on the psych of men with intent to increase male representation in psychology. And we're working with some funders on that front to allocate some scholarships to work to increase awareness at the undergraduate level of this area of study, and just really to get the word out and let people know this is a thing. You can get involved, um, and it can be enjoyable, it can be helpful, and you can make a good living doing it.
Mhm.
Like that last part's a very big deal.
Yeah.
My 18-year-old would be going into teaching if he thought it would make him more money.
Mhm.
This is a fact.
Yeah, it's interesting what role that plays on decision making, particularly, I would just say in general, for males who, you know, have this sort of career, from the youngest age up, right? This sort of career focus and how to be, as you said, the traditional roles of provider. It'd be interesting to see how those organizational elements you put in place play out. And I'm certainly hopeful that we'll have more male representation in the field. Again, not to disparage or in any way minimize women in the field. I'd like to
Or
maybe,
or anyone, right?
or anyone. Yeah, that's right.
Yeah.
That's right. Well, I'd like to maybe ask for your advice here, Dan. You've been very successful in making a name for yourself. Talk about a career, right? You've been very successful in making a name for yourself and creating a platform in the field. What advice would you offer for mental and behavioral health professionals who are looking to make a name for themselves or create such a platform?
Can't keep everybody happy, no matter what. As soon as you raise a flag, some people are gonna salute, other people are gonna try to burn it down. That's just a fact. And in the field of men's mental health in particular, it's kind of a third rail,
Mhm.
right? Because what I what I have experienced is the folks that I know who are the most sensitive about the other side as being zero sum game and all or nothing thinking themselves have a fairly zero sum kind of misandry, misogyny is against women, misandry is against men, have a kind of tacit, well, we need to be supporting everyone except for cishet men.
Mhm.
And I'm like, wait a sec, why? Well, because traditionally power privilege, yes, acknowledged all of that. And we're half the population,
Mhm. Mhm.
right? Like males generally, and then you start slicing and dicing specific, groups out of it. And so I would say first, get ready for blowback because people are going to have their issues with what you're going to put out there. But for me in particular, I'm a kill them with kindness kind of guy. I don't have like I'm not anti anyone. I'm looking to lift up men and boys and empower the people that love them and want to care for them. And I am deeply suspicious of people whose agenda begins with they're the problem. Watch out for them. You got to come over here and play like I don't in the work that we do, marketing, let's say you got one tail over here and you got another tail over here, we're not pandering to the tails. And it's sort of, frankly, just for the odds, like, 66 and 2/3 of the people in the middle, they're the ones that we can probably actually connect with and dialogue about. The tails made up their minds a long time ago.
Yeah.
And a lot of times they just want to spar and get into, and that's fine, but that's not really what I'm looking to do.
Well, that's great advice. I would love to invite your advice one more group, right? Which is undergraduate, medical, graduate students, right? This is the next generation who are entering or considering entering the behavioral health field. What advice would you give to them?
The, those fields are transforming more rapidly than ever before. So mental health, this was kind of a cool one of the other psychologists that works with me here was showing me the top 10 prompts for ChatGPT last year included in the top 10, but it was like 3, 6, and 10, like mental health, well-being, like therapy kinds of questions. 2025, those are the top 3.
Oh, wow. Okay.
The top 3. And so I'm not one of these, the AI sky is falling thing. However, in the early 20th century, you had these guys in factories saying, "Oh, we're always going to need men on the line," and no, you don't.
Mhm.
It was automated, right?
Yep.
And I know folks that are like, "Oh, this is about feelings and relationships." Yes, agreed. And both in medicine broadly and in psychology, everyone is double checking with AI. Everyone is writing, progress notes using recordings and AI, asking penetrating questions, both on the provider side as well as on the patient
Mhm.
side, and what that's going to look like in terms of clinical protocols and practice and what best practices are. I couldn't tell you. But I'm speculating and looking at what some trusted colleagues of mine are doing. But I would say get into it. Like get out there, find what makes you passionate. For me, it's fatherhood and men's issues. For somebody else, it's working in an HIV clinic in an inner city, FQHC or whatever. Um, but actually, let me tell you, my very first day at UC San Diego, not at actually, it was at University of Maryland. The training directors came out and said, "You have 3 job choices. You can be a researcher, which is what we are, and of course, that's the right thing to do." I'm giving you the subtext. 2, you can, just teach, not do research at a small liberal arts college, but poo-poo, those jobs are going away. Or 3, you can be a clinician, but why would you be in a research program? So it was basically like be a researcher. So folks
Wow.
have agendas about how to develop. And I raised my hand and was like, "What are starting salaries for each of those?" Right? Entitled white guy. And they told me, and I was like, "Well, I'm gonna have to figure something else out. None of those are gonna work." Right? And so then I was like, "Okay, I'm gonna get a doctoral minor in industrial organizational psychology and start looking at business practices and the intersection of business and behavioral health." And that's what got me into startups
Mhm.
and got me direct hands-on experience with business operations and being able to translate that into small business. It's gonna be the same as with how do we incorporate tech? How do we keep our eye on some of the sociological changes that are happening, and what's the meaning of psychotherapy? What's the meaning of medicine and the sense of trust or not with those? So my advice is don't take professional development advice as usual. Back in the 80s, psychiatrists could, before managed care came in, you could just set up a practice, kill it, make a ton of money, and then move on. With managed care and insurance, very, very different,
Mhm.
right? And so that kind of transformation, particularly when you start looking at psychedelic assisted psychotherapy, and that being pretty much the next big thing in psychiatry, big things are coming and changing. But no matter what, I encourage folks to really stop and index on what gives me a sense of meaning and follow that.
That's great advice, Dan. I appreciate that. I hope our audience is leaning in for that. Well, Dan, I know we close each of our shows. You probably have heard this. We close each of our shows with a lightning round. These are some quick questions designed for quick answers. Are you ready for that?
I mean, uh, quick answers. Have you met me? But okay, sure,
All right, well, let's get into it. You ready?
sure.
All right. What's one phrase you tell new fathers to ground them?
be involved.
What is your favorite book, clinical or personal?
Dungeon Crawler Carl. I'm a massive science fiction nerd.
Wow, I have to look that one up. What's one
It's up and coming. They just like I'm telling you, Seth MacFarlane just bought the rights to
Oh,
it.
really?
You read my lips. Dungeon Crawler Carl. It's coming. Anyhow, keep going.
Okay, I love that. I always like when I hear a new one. What's
Mhm.
one myth about men's perinatal mental health that you wish more providers understood?
Men don't have feelings.
What is a strength-based masculine trait you think is wildly misunderstood?
Action empathy. People think you're a crappy listener, but you're acting on what you understand the other person's needs are.
Hmm, resonates. How do you recharge when the demands of fatherhood and leadership pile up on you?
I go surfing, I hang out with my friends, and in the past year or so, I've started reading books like Dungeon Crawler Carl in the bath.
Nice, nice.
Didn't used to take baths, but here we are.
Well, that's great, Dan. Thank you. Dr. Dan Singley, thank you so much for joining us here on Doc Secret and sharing your journey and perspectives with us. Really appreciate you coming on the show.
Thank you. It's been an honor.
If you liked today's episode, please like and subscribe, and most importantly, share this podcast with others you think may benefit from the Doc Secrets shared here today.